Thank you, Dr. Abdulaziz. Good morning, everybody. It's good to be here today. And now let's shift the gear because we've been hearing about electrophysiology from electrophysiology perspective. Now we'll go to surgical perspective. So as we know that atrial fibrillation is the most common arrhythmia affecting adults. It has a 5-fold increase in risk of stroke, and it's responsible for 40% of overall stroke. And if you look at the males who has atrial fibrillation between age of 55 and 75, they have actually a drop in their, an increase in their mortality and drop in their survival. And if you look at the surgical data, despite that we know that atrial fibrillation has a major tremendous effect on the patients, yet only 50% of the patient, they get a surgical ablation during their cardiac surgery. So we know that the prevalence is increasing, the number of patients are increasing, there is increase in complication of atrial fibrillation, including stroke, survival, mortality, though we still have issues with management. So if you look at the Heart Rhythm Society, they define atrial fibrillation, like they divide it mainly into the 4 main categories, which either paroxysmal, and this will last for 7 days, persistence between 7 and 1 year, long-standing persistence when you have atrial fibrillation for more than 1 year, and permanent atrial fibrillation when the cardiologist and the physician and the patient reach to agreement that this is it. We're not going to go for more rhythm management. So we know that the cornerstone of medical management is anticoagulation and rate or rhythm control, but we know that they have very high failure rate. And if we go to the history of development of atrial fibrillation surgery, Dr. James Cox stayed in lab for years and years trying to look into where does the focus come from and where was the best way to do the ablation. And we know that he started doing the cuts and sew technique, which we'll show later, and that was very complicated. And since then, the Cox-Maze 3 became the gold standard treatment of atrial fibrillation in surgical community. And if you look at our guidelines, so we actually divide this into 3 main categories. Either a patient who comes for a mitral valve surgery, and this is clear cut because you're going to open the left atrium no matter what. But what about the patient who comes for aortic valve or CABG? That it's you don't need, like, you're not opening the left atrium. What should we do with that? And the last group, which is the standalone patient who has atrial fibrillation, they are a medical therapy that's being failed, and they go for ablation and that's being failed. What should we do with this group of patients? So I personally trained with Dr. Badwar, who's the primary author of this STS guidelines. So I don't want to spend a lot of time, but any patient comes to your operating room with atrial fibrillation, they deserve to go for a surgical ablation. That's the end story of this slide. So let's divide it. Why do we do surgical ablation? Because it improves the left ventricular function, putting the patient in sinus rhythm, and it decreases the left atrial size and will lead to remodeling, and this will decrease the risk of recurrent atrial fibrillation, and it will reduce the risk of stroke because we always close the left atrium when we do the surgical ablation. So if you look at, we even looked into doing atrial fibrillation. It's just going to put the patient in sinus rhythm. And is it safe or not? Because it's always about safety. As a surgeon, it's going to increase my mortality. It's going to increase my complication. But if you look at the risk-adjusted mortality, actually doing a Maze procedure for a patient, it reduces the risk of operative mortality because you're preventing putting patient atrial fibrillation and the consequences of medication and management of atrial fibrillation post-op. So overall mortality is actually better if you go for a Maze operation during your primary operation. And if you look at the long-term outcome of mitral valve surgery with Cox-Maze, we know that at 84 months of follow-up, you still have a 66% freedom from atrial fibrillation, you're being in sinus rhythm if you use antiarrhythmic medication. And the most important factor to have recurrent atrial fibrillation after Maze procedure is the duration of atrial fibrillation. So that's why we say if the patient have atrial fibrillation, this patient should come for ablation therapy as soon as possible. Most important also surgeon experience. Because as you guys get training in our surgery community, we think that doing maze procedure, it's just like a adjunct to the surgeon, but I don't believe in that. I personally have a very heavily training where we do about 4 to 6 cases a week of maze, and I was involved in even in trials and research, and it showed that when you have when you exactly know what you're doing, you will have a better outcome. And the other thing is what energy source we use, because most of our surgeons, they'd like to use RF because RF is faster and it's easily available. But cryo, the machine is bigger, you have to have a gas in the OR, it takes a lot of resources. But cryoarrhythmia, cryo ablation showed better outcome, and we'll show that on subsequent presentation. So in patient who comes with mitral, it's easy to discuss because we open the left atrium. But if patient comes for aortic valve or CABG, when you're not going to open the left atrium, you still have data that support that patient who are going for AVR or CABG, you decrease their mortality and improve their long-term survival by doing the maze procedure or ablation procedure. Some people, they prefer to use a non-open technique, which is the BVI and left atrial appendage closure. My argument is that if your patient comes to your OR with persistence or longer standing persistence, don't use BVI because we know the outcome is poor in surgery. You will have a less than 60% success rate. So if the patient comes to your OR, do your bypass and then open the left atrium and do the full maze, and that will give the patients a better outcome. And we know that why we have a failure rate, because left atrial is enlarged, and as I said, duration of atrial fibrillation, it's very important. So we have a paper also came from West Virginia that they looked into 1-year outcome if the patient goes CABG, and this came from STA's database, and we showed that if the patient goes for ablation therapy, they have a better mortality at 1 year. And if you look at long-term efficacy and safety, if you do Cox Maze for non-mitral cases, which is CABG or AVRs and all kinds of procedure, we can see that at 5 years, the freedom from atrial fibrillation or being in sinus rhythm is 80%. So what about the standalone cases? When do we do standalone maze procedure? If you have failed medical therapy, failed cath therapy, patient has long-standing persistence atrial fibrillation, and they have a problem with intolerance of their anticoagulants. So the argument, and this is from cardiologists, that this is an invasive procedure, we're exposing patient for surgery, yet we have solid data that the mortality rate of this procedure, it's like as good as any mortality even in transcatheter therapy. Our mortality is 0.74% in the STS database. And most of standalone data, though, it's been driven from minimally invasive approach. But there is a new emerging data come from where I trained, and I was part of the paper, when we look into robotically assisted standalone maze, and it's actually the mortality rate was less than 1%. So if you look at standalone, there was, if you look at AATS database, they divided that into 3 main categories. Either you do bilateral mini thoracotomies with the thoracoscopic bipolar RF, and you do the left atrial management, or you do unilateral right thoracoscopic, which you call the posterior encircling, or you go for a posterior wall, which you call the conversion technique, when you go from the subxiphoid and you burn all the back wall of the left atrium. So the standalone, it also depends on going into doing mapping again. Like you do this procedure, you send the patient to electrophysiologist, they go and they do mapping, and they look into, they complete the isthmus lesion, and they look into if there is any skip lesion, then they can complete. So we call this as a hybrid procedure, because there will be an epicardial followed by a catheter ablation, and there was the both should be done within 6 months, because you don't want to have the patient to have to call it a failure of the procedure. So the early outcome was in the paroxysmal atrial fibrillation, they have 75 freedom from AFib, and persistent 67%, and long standing it has 43%. So the outcome is not good. But if you look at surgical operation for atrial fibrillation during mitral valve surgery, This is a much bigger scale procedure. And here, this actually, when it came back, it confused our surgical community, because Dr. Mark Gilinov, he's a robotic surgeon from Cleveland Clinic. When he looked into, okay, if I'm going to do a mitral, I'm just going to isolate the pulmonary vein or just do the full Cox-Maze 4. And he came up that, he said, oh, both procedures have similar outcome with no significant p-value. And then from the same group, they actually came up with a follow-up paper and they said, no, that was actually a wrong statement, because doing BVI alone associated with higher risk of recurrent of atrial fibrillation, and doing biatrial maze was associated with better outcome. So, and again, people start argument, why should we do biatrial maze? Why didn't just do the left atrial maze, given that 70% of the atrial fibrillation comes from the left side? But if you look at the data which came from a meta-analysis, that there was no difference in biatrial versus left atrial in keeping patient in sinus rhythm. And there was, if you look at the cerebrovascular event, there was no difference. But the biatrial maze associated with higher risk of pacemaker. And again, but if you look at another data, which showed again that if you look at a subset group of patients and different surgical patients, we still see some diversity. If you have a long-standing persistence or persistence, doing left side maze alone associated with a lower risk of keeping patient in sinus rhythm, though biatrial maze associated with higher risk of sinus node dysfunction and permanent pacemaker. That's why you have to have a systematic way of doing the surgical ablation to prevent the complication. This paper came from Ralph Damiano. I was hoping to be with us in this meeting, but he was actually busy. He had a very large group of patients, which showed that doing Cox-Maze 4 associated with an excellent outcome of freedom from atrial fibrillation reached up to 78%. And this was, again, the recurrence of atrial fibrillation was associated with the duration of atrial fibrillation. So referring patient earlier for intervention associated with excellent outcome. And if you take the argument of why should we do that, if you look at the patient who came for cardiac surgery, who have a Cox-Maze 4, compared with untreated atrial fibrillation, the survival benefit was clearly there. And if you match the Cox-Maze 4 with the normal population without atrial fibrillation, their survival match. So there is a survival benefit of doing this procedure. I will end up with what is the trends now in the United States where I was trained. So if patient comes for a mitral valve, for sure he will get most likely maze because you're opening the left atrium. But there is now, as you can see here, there is a fire in like you see that, in CABG and AVR and start to increase. Standalone is still steady, but I believe it comes from driven of surgeon and cardiologists. So they have to go into, or electrophysiologists, they believe that surgical standalone maze, it's part of the spectrum of management if patient failed their catheter ablation. So in conclusion, there is underutilization of surgical atrial fibrillation management for sure, and we know that from the data. Cox-Maze 4 can be done for all patients coming for cardiac surgery, and there is growing evidence that solo maze for patients who failed medical and transcatheter therapy. Biatrial versus left atrial is still a debate, but I believe you have to depend on type of atrial fibrillation. If my patient comes with a paroxysmal atrial fibrillation, I'll be happy to do only left, but anything other than paroxysmal, I'll do biatrial maze. And there is a lot of evidence growing that the safety and efficacy. So surgical maze has to stay. Thank you so much.